Hi, welcome to this NEET PG 2024 Anatomy Questions Recall session by Manipal MedAce. Hope the exams went well, both session 1 and session 2. Most of the students felt that the exams were a little bit on the tougher side, and if it is tougher, it will be tougher for everyone. So you don't have to worry, you've given your best, and just hope that you'll get the best of the results. So what we'll try to do now is we'll try to quickly revise the questions that were asked in the NEET PG 2024. Most of these are recall questions. These may not be the exact questions. There will be some disparity. We'll try and rephrase these questions and explanations as quickly as possible as we get in more inputs. So let's get started without wasting much time. One other question, possibly in session 1, that was asked was from general anatomy, and the question was something like this. Okay, so which site, right? So we'll just go through the question. Which site of fracture can inhibit linear growth? Okay, now here, this is the key term, right? Linear growth. So they're asking about which site of a growing bone, if injured or affected, will affect the linear growth of long bones, right? Now, all of us know that a growing long bone will have these parts, right? It will have a diaphysis, then it will have an epiphysis. The upper end of the diaphysis is called as, this is the metaphysis, right? And the epiphysis and the diaphysis are separated by a piece of hyaline cartilage, and this is what we call as epiphyseal plate, right? So here we have the epiphysis. This is the epiphyseal plate of cartilage. This is the metaphysis, and of course the shaft, this is the diaphysis, right? Now, which of these regions, if affected, will lead to decreased linear growth of long bones? There is no doubt that the metaphysis is in fact the most active and growing region of any bone. But if epiphyseal plate gets injured, this affects the linear growth of the bone, right? This is the region where the bone grows in length, right? So if epiphyseal plate of cartilage gets affected, this will result in decreased linear growth. Okay, remember, metaphysis is the active growing region, but the bone grows in length from the epiphyseal plate, right? So the correct option here is the epiphyseal plate of cartilage, right? So this is regarding the first question that was asked, right? Now hope this is clear, right? The explanation is pretty simple. Linear growth of bone occurs at epiphyseal plate. That's it, right? Now, this was one more question which most of the students said possibly there was an image based question. We have taken this image from Google depicting the deformity that was probably shown in the question, right? Now, the question read like this: a child treated with above elbow cast, right? Above elbow cast for injury of the upper limb. So they have not specified what type of injury, what type of fracture, what type of dislocation it is, right? So what they've suggested is injury of the upper limb presented with following deformity as shown in the image. So this is the deformity. Now, the question is to identify the deformity, which side the deformity is. We'll come to that. Okay, so which of the following is the possible site of injury? Now let's try to analyze this image. So which side is actually affected? Okay, if you take a closer look, right, now this is the axis of the arm, and here this is the axis of the forearm, right? So we have this angle, right? What is this angle? This is the carrying angle which keeps the forearm away from the trunk, right? When the arm and the forearm is in supinated position. Now, if you take a look at this carrying angle is lost, right? So you cannot make out the carrying angle, and this is a deformity called as cubitus, varus or valgus. This is an adduction deformity where the upper limb is pulled towards the trunk, right? So this is a varus deformity, and this cubitus varus deformity is also referred to as what? The gun stock deformity. I'm sure Daivik sir will cover this again in detail. So this was like, you can say an integrated question between like anatomy and orthopedics. Okay, so where do you see this gun stock deformity? The answer is like pretty straightforward. This is seen in the supracondylar fracture of the humerus. This is one of the well-known complications of the supracondylar fracture of humerus, particularly in case of children or pediatric age group. Right? So what is the key to solve this question? To identify which is the affected side. Okay? And how do you identify this? You identify this if you have the knowledge of what is carrying angle. Right? So this is where anatomy comes in handy in solving questions of orthopedics. Right? Fine. So this was the second question. Then the third question was on the superior orbital fissure. Okay? Now some of the students said like there was a image from the cranial cavity. So cranial cavity was actually shown, and some of the students also said that like there was a CT or an MRI image where they had marked the superior orbital fissure, right? But it was superior orbital fissure, and the question was almost like this with possibly these options. Injury to the superior orbital fissure can lead to which of the following sensory losses or loss? Right? Now, the options given were sensation in the upper lip, the loss of sensation in the upper lip, sensation loss over the scalp and dorsum of the nose, then sensation loss in lower lip, sensation loss in the nasal cavity and the nasopharynx. Now, let's try to analyze this question. Okay? So, superior orbital fissure. So, what we need to recall is the structures passing through the superior orbital fissure. This is the right-sided superior orbital fissure divided into 3 compartments by the tendinous ring of Zinn. And on the superior lateral compartment, we have the lacrimal nerve, frontal nerve, and the trochlear nerve. We'll, for time being, forget about the other structures. We'll concentrate only on the nerves because this question is on nerves, right? So let's forget about the ophthalmic vein, the recurrent meningeal artery, all of that. So what we have here, the lacrimal nerve, the frontal nerve, and the trochlear nerve. Now, the other structures that pass through the intermediate compartment, we have the superior division of oculomotor nerve. So this is the oculomotor nerve, superior division and inferior division. Then we have, let's say, the nasociliary nerve, right? And then we have, let's say, the abducent nerve. Now, since the question is very clearly saying that sensory loss, what we can do is we can rule out the motor nerves. Now, what are the motor nerves? The oculomotor nerve, right, which supplies most of the extraocular muscles. Then we can take out abducent nerve, LR6, which supplies the lateral rectus. We can also take out trochlear nerve, right? Now, trochlear nerve supplies superior oblique. Okay, so once we have taken out all the motor nerves, so we have like the sensory nerves remaining, right? And what are they? Lacrimal nerve, right? Then we have frontal nerve, and then we have nasociliary nerve. Now, what is the function of these nerves? Let's try to recall. Okay. Now, if you remember, lacrimal nerve will supply the lateral part of the eyelid, skin of the eyelid. Okay, fine. Then, what about frontal nerve? Frontal nerve gives off 2 important branches, right? Supraorbital and supratrochlear, which will supply the medial aspect of the scalp as far as the vertex. Okay. Yes. Then, what about the nasociliary nerve? The branches that come from the nasociliary nerve will also supply the dorsum of the nose, right? If we talk about the upper lip, the sensory innervation is mainly by the branches of maxillary nerve, right? But maxillary nerve never comes out of superior orbital fissure. Maxillary nerve comes out of or passes through foramen rotunda, right? So that is not the option. Then sensation loss in the lower lip, the lower jaw region, the lower lip region is mainly innervated, or the sensory innervation is carried by the mandibular nerve, which of course passes through, yes, foramen ovale. We know the male structures, right? So the possibility of the upper lip and lower lip is ruled out, right? Then sensation loss in the nasal cavity and nasopharynx. Again, when we talk about this again comes mainly to the branches of maxillary nerve and the pterygopalatine ganglion, but never the ophthalmic division, which gives rise to these lacrimal nerve, frontal nerve, and nasociliary nerve. Right? So remember, the ophthalmic division of the trigeminal nerve gives rise to these three branches, lacrimal, frontal, and nasociliary, and these are mainly concerned with innervating the scalp, the root, and the dorsum of the nose. Right? So the correct option here is the sensation loss over the scalp and dorsum of the nose. I'm not sure if this was the exact option that was given, but when we solve these MCQs, one way of cracking them is usually, not always, okay? Not always, but usually the longest option seems to be the correct one, okay? That just gives you a clue. Of course, like there are two options which are the same length, but usually this is one more clue that like which is possibly the answer. Done? Right. Now, let's move on to the next question. So the next question was on tongue. See, tongue is a favorite topic of your examiner. Let it be your university exam, let it be your entrance exam. There never goes a question paper without a question on the tongue. Let it be on gross anatomy, let it be on its nerve supply, let it be on development, histology. So you will have one question from tongue. So you can never ignore this topic, right? And we have covered this in detail, right? Now, the question is, in which of the following papillae are taste buds absent? Okay, now we know that if we draw the entire outline of the tongue, okay, so let's imagine this is the posterior part of the tongue and this is like the anterior part. So we have what? The sulcus terminalis, we have the circumvallate papillae, right, which lie in front of sulcus terminalis, the largest of the lingual papillae. Then we have the follate papillae, which lie on the margins. So this is circumvallate, this is, let's say, the follate. Then we have the filiform papillae, which are like scattered throughout. Okay, these are like the most numerous of the papillae, right? And then in between them we have the fungiform papillae, right? Now, which of the following papillae taste buds are not seen? Remember, taste buds are the characteristic feature of circumvallate papillae, right? The circumvallate papilla, if you recall, it has like a surrounding moat, then it has a narrow base and a broad apex, right? So this is how the circumvallate papilla look, and taste buds are usually located along the lateral wall of the circumvallate papilla, where we have the lining epithelium, right, which is stratified squamous, non-keratinized, right? Now this is circumvallate papilla. So circumvallate papilla have taste buds. Then the filiform papilla look like sharp conical projections with a sharp tip, right? Then we have the fungiform papilla, which again look like mushroom shaped. Of course, there is no moat. And then follate papilla appear as parallel ridges, and these are prominent only in case of animals, right? Now, one other peculiarity of the filiform papilla is this is the most numerous of the lingual papillae, and tip of this is keratinized. Okay, so the tip of filiform papilla is keratinized, and because of this keratinization, even if you have taste buds, it is of no use, right? So which is the papilla that will never have the taste buds? It is filiform papilla, right? Irony is, this is the most numerous of the lingual papilla, and yet it does not carry taste buds. Why? Because this is the only papilla of the tongue whose tip is keratinized, right? Done. So the correct option here is the filiform papilla, right? Done. Okay, let's move on to the next question. Now this question was on gag reflex, right? So let's read the question. Which cranial nerves are involved in brainstem lesion? Okay, brainstem is the clue for you. So brainstem lesion, that results in loss of gag reflex. What do you mean by gag reflex? Whenever you touch the posterior part of the tongue or the palate, usually you have a sensation of vomiting. This is because of forceful contraction of the pharyngeal muscles and elevation of the soft palate. This is what gag reflex is. Gag reflex is used to check the integrity of cranial nerves, right? So you have learned this also in cranial nerve examination, right? Now, what nerves are responsible for gag reflex? Let's talk about, if you want to elicit gag reflex, you have to touch the posterior part of the tongue, right? The posterior part of the tongue, which nerve carries the sensory innervation from posterior part of the tongue? Again, this is going back to the nerve supply of the tongue, right? So we know that the anterior 2/3 of the tongue, right? Again, if we just draw the outline of the tongue, we'll just draw it again. So again, if we draw the outline of the tongue and we draw the sulcus terminalis, the circumvallate papilla, right? The anterior part of the tongue is supplied by lingual nerve, okay? Lingual nerve carries general sensation and the taste sensation is carried by chorda tympani, right? But this is except for what? The circumvallate papilla. So the circumvallate papilla and the posterior 1/3 of the tongue, this is carried by the glossopharyngeal nerve. Glossopharyngeal nerve is responsible for carrying both the general sensation and the taste sensation from the posterior 1/3 of the tongue. When we go to posterior most part of the tongue, it is from the vagus nerve, the internal laryngeal branch of vagus nerve, right? So if you're touching this part of the tongue, which nerve is carrying the afferent impulse of touch? It is the glossopharyngeal nerve. Done. That is done, no? Right. Now, which nerve is responsible for contraction of the palatal muscles as well as the pharyngeal muscles? Even though the pharyngeal muscles and the palatal muscles are innervated by the cranial root of axillary nerve, the cranial root of axillary nerve gives its fibers to the vagus nerve, and the vagus nerve carries these fibers to the palatal muscles as well as the pharyngeal muscles, right? So look for an option where you have both glossopharyngeal nerve as well as vagus nerve, right? So where is that option? So where is glossopharyngeal nerve? Glossopharyngeal nerve is here, 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 and here. Okay, all have glossopharyngeal nerve, right? So that is done. What you need to look? Vagus nerve. So where is vagus? Here is the only option where you have the vagus. So the correct option is this, the 9th cranial nerve and the 10th cranial nerve. Okay, so this is regarding the gag reflex. Done? Right. Okay. Now, let's move on to the 6th question. Now, the question was, the presence of fecal material leaking from umbilicus is indicative of which condition? Now, some of the students said, like, the question was on what is the diagnosis, like what is the clinical condition. The other school of students said that, like, it was not about the abnormality or the congenital deformity, but it was about the covering of the deformity, right? Fine. Now, going by what deformity they were possibly asking. Now, if you just recall the abnormalities of vitalointestinal duct, we know that during development, the vitalointestinal duct passes through the umbilical ring, right? Now, if you consider this as the anterior abdominal wall, this as the umbilicus, and let's say here we have the coils of intestine, right? Now, if the proximal part of the vitalointestinal duct persists and rest of it degenerates, what do you call this abnormality? This is called as Meckel's diverticulum, right? So this is Meckel's diverticulum. Then similarly, if you have, let's say, the umbilicus, then let's say you have the gut tube, right? And you have the vitalointestinal duct persisting in the middle, then disappearing in both proximal and distal region. Okay, now this gives rise to umbilical cyst. Then the third kind of anomaly is where you have the umbilicus, right? You have the coils of the small intestine, and then there is complete patency of what? The vital intestinal duct. So what happens is the contents of the intestine, that is the fecal material, can freely pass through the vital intestinal duct and come out of the umbilicus. So what do we call this abnormality? This is what we call as the umbilical fistula. Now, what is fistula? Fistula is when you have an internal tubular structure which is connected to the exterior, the external surface. That is basically fistula. The branchial fistula is one such example, right? Anal fistula or fistula in ano, where the anal canal communicates with the exterior of the skin. So this is the umbilical fistula. So what's the option? So option we have is umbilical fistula. Done. So this was one question, right? Done. Now, some of the students said like there was a cadaveric image where they were not able to identify the nerve very clearly. Okay. Now, I have taken this image from one of our own video, a dissection video. Now, what we have here is the dissection of the brachial plexus, and possibly this was the question. Okay. Identify the structure shown in the image, and the structure pointed was possibly this. Okay. Now let's try to identify what is this. The first thing I want you to notice is this is the neck region, this is the upper limb, so this is the axilla, and the muscle you are actually seeing is the pectoralis minor, or the key muscle of the pectoral region. Now I want you to notice two important nerves here. One is this nerve, which is lying medial or above the proximal border of pectoralis minor, and then there is one nerve which is actually piercing the pectoralis minor, or sometimes it lies along the lower border of the pectoralis minor. Now what is this nerve? Remember, this is the lateral pectoral nerve, right? And the one which is piercing pectoralis minor, this is the medial pectoral nerve, right? So medial pectoral nerve sometimes lies on the lateral side of the distal border of pectoralis minor. Now this is a little bit confusing, right? So remember, the name lateral pectoral nerve and medial pectoral nerve are not because of their position. In fact, as we can see here, the lateral pectoral nerve is medial, whereas the medial pectoral nerve is slightly lateral. They are called so because of their origin, right? They arise from the lateral cord and medial cord respectively, and that is why you call them as medial pectoral nerve and lateral pectoral nerve, not because of their position. Okay, so if you have a nerve that is lying along the lower border of pectoralis minor, it has to be the medial pectoral nerve. Okay, now suppose if there is something above the upper border which is piercing the clavipectoral fascia, then it has to be the lateral pectoral nerve, right? Remember, the long thoracic nerve lies close to the axilla or the lateral thoracic wall, and intercostobrachial nerve comes out from the second intercostal space, right, joining the medial cutaneous nerve of the arm. That's the lateral cutaneous branch of the second intercostal nerve. Okay, so the correct option here, which is either piercing or lying lateral to the lower border pectoralis minor, is the medial pectoral nerve. Right? Done. Then let's move on to the next question. Now, this question was on the structure related to the medial malleolus. Right? Now, the question was, which tendon is located immediately behind medial malleolus? Some of the students also said that there was a little bit information related to when the foot is inverted. When the foot is inverted, that is, you lie the foot on its lateral border, which structure is felt immediately posterior to the medial malleolus? Some of the students said that like there was an artery in the option, and most of the students said that like tendon was given. Okay, so what we'll do is we'll stick to the tendon that was asked. And let's try to dissect this question. Okay, when we talk about the structures along the medial malleolus, okay, so what we are talking about is, so let's imagine we have the medial malleolus of the tibia like this, and then we have like the skeleton of the foot, right? We have a retinaculum, right? So what is this retinaculum? This retinaculum is called as the flexor retinaculum, right? Now, structures passing deep to flexor retinaculum include, so what are the structures we have? First we have is a tendon, right? So first we have is a tendon. Now, how do we remember this? Can you tell me the mnemonic for like flexor retinaculum? Remember, we have two mnemonics. Like one is for the structures passing deep to extensor retinaculum of foot. One for the structures passing deep to flexor retinaculum of the foot. The structure passing deep to flexor retinaculum of the foot can be remembered by the mnemonic: the doctors are not here. Okay, where the first letter will tell you about the structure passing deep to the flexor retinaculum. Whereas when we talk about what? The extensor retinaculum, it goes like this, right? The Himalayas, right? The Himalayas are not dry places. Okay, so first structure we have is what? Tibialis posterior. Okay, so what is this? Tibialis posterior. The second structure we have is the flexor digitorum longus. Okay, flexor digitorum longus. Then what do we have? We have the posterior tibial artery, right? So posterior tibial artery. Then we have the nerve. Okay, so this is the tibial nerve, right? Then we have one more tendon, and what is this? This is flexor hallucis longus. Okay, so structures passing deep to flexor retinaculum of the hand, structures passing deep to the extensor retinaculum of the foot and the flexor retinaculum of the foot are again favorite topic of your exam notes. Okay, so this is how you can remember them. What does the Himalayas are not dry places stands for? So we have tibialis anterior, we have the extensor hallucis, then we have the anterior tibial artery, then we have the deep peroneal nerve, then we have the extensor digitorum, and then we have the peroneus tertius, right? So this was possibly one question. Now, if the question was on artery, which artery is related posterior to the medial malleolus, you have the answer. And what is that? It is the posterior tibial artery. Okay, what is the fate of the posterior tibial artery? Terminates by dividing into medial and lateral plantar vessels. Okay, done. Now, this is regarding the structures passing beneath the flexor retinaculum and posterior to medial malleolus. Right, done. The next question. This was a histology question and an image-based question again. So the question was pretty straightforward again. The epithelium shown in the image is found in which structure? So this is about like identifying the type of epithelium. Okay, as soon as you see this image, what strikes to your mind? What type of epithelium is this? This is the transitional epithelium. Okay, this is the transitional epithelium. Now, what is transitional epithelium? The other term used for this is the urothelium. Now, how do I say that this is urothelium? You can see these umbrella shaped cells, right, which is forming the topmost layer, right? So urothelium is the characteristic lining epithelium of the urinary tract, right? So it lines the ureter, then it lines the urinary bladder. So which of that option is here? So the option that you have is ureter, right? Done. Now, what about the gallbladder? Remember, gallbladder has simple columnar epithelium with microvilli. What is the function of microvilli? Microvilli increases the surface area of absorption, helps in concentration of bile. Right? Done. Then what about trachea? Trachea is a part of respiratory tract. Hence, it is lined by respiratory epithelium, which is pseudostratified ciliated columnar epithelium. Then, vas deferens, right? So, vas deferens belongs to what? The male genital system, okay? And it is not lined by the urothelium. Done? So, this is how you rule out the other options. Of course, it's a straightforward question. If you remember the slide of ureter, this should not be difficult, right? Done. Okay. The next question. Now, this was a case-based question, and the question was, a 42-year-old male presents with loss of sensation in the lateral three fingers. As soon as you see this, like, you will get excited. Oh, this is about median now, right? Now, let's see the next part. Loss of sensation in the lateral three fingers, then difficulty in flexing the thumb, okay, which is suggesting possibly the involvement of the flexor pollicis longus, right? Now, where is the most likely site of nerve injury? Now, so these two are like ruled out, okay? We have ruled out ulnar nerve, right? Lateral three digits, sensation, function of median nerve. Now you have to decide whether it is median nerve in hand or median nerve in forearm. How do you decide this? The clue here is the difficulty in flexing the thumb. So flexion of the thumb is the primary function of your flexor pollicis longus, which is a deep muscle of front of the forearm, which is innervated by anterior interosseous branch of median nerve, which is given off higher up in the forearm, right? So what should be the correct option? It is the median nerve in the forearm, right? Why? Because this is due to involvement of anterior interosseous nerve, okay, or the involvement of the median nerve higher up in the hand. So both anterior interosseous nerve is involved, and also the sensation over the lateral 3.5 digits are involved. And if the injury to median nerve is higher up, it is more likely that all your thenar muscles will also be involved along with the first two lumbricals, right? Done. Now, the next question was again possibly a case-based question. Now, this was clearly mentioning that the male patient or the female patient was unable to button his or her shirt. Okay, this is an important clue, right? Now, and he cannot perform the O sign. Now, this is the O sign, right? So, how do you do this? This is the O sign, right? Now, which muscle is most likely affected? Now, let's try to understand what is required for buttoning of the shirt. Okay, the first thing is you require the muscles of your thenar eminence, right? And in that, if you are unable to make O sign, what action is lost, right? Typically, the flexion of the thumb will be lost, and apart from flexion, abduction will be lost. So what is abduction of the thumb? If this is the anatomical position of the thumb, where the thumb faces like medially, this is abduction, adduction, flexion, extension, opposition, where you touch tip of the other fingers, right? So let's see the options carefully. We have flexor pollicis longus is one option. Okay, let's keep it aside. One is adductor pollicis. What is the function of adductor pollicis? This is adductor pollicis, right? Then opponent's pollicis, the function is this, right? Then abductor pollicis brevis. So abduction, right? You want to move the thumb away from the plane. This is abduction, right? So the correct option here is the abductor pollicis brevis. Fine, because if you want to make the O sign, the abduction of the thumb is absolutely necessary. With your thumb adducted, you can never make it, right? So here the possible answer is the abductor pollicis brevis. So the thumb will be in adducted position. You can never abduct it, right? Okay. The last question. Now, a 40-year-old male has tenderness in the hamstrings. Okay. Then which nerve supplying a hybrid muscle is most likely unaffected? Now, let's talk about the hamstrings, right? Hamstrings, we have semimembranosus, semitendinosus, which are called as like true hamstrings. Okay. Then we have what? We have the modified hamstrings. And what are the modified hamstrings? The modified hamstrings we have is the ischial part of adductor magnus and the long head of biceps femoris, because they follow certain criteria. Now, If we are talking about a hybrid muscle, what do you mean by a hybrid muscle? Hybrid muscle is something that has dual innervation. Now, which of these hamstrings do have dual innervation? If you carefully think, it is the adductor magnus, right? It has an adductor part and an ischial part. So it has an adductor component and a hamstring component, right? The hamstring component is innervated by the tibial component of sciatic nerve, whereas the adductor component is innervated by the obturator nerve, right? So what do we have here? So this is about the obturator nerve. Then femoral nerve, it will not supply your hamstrings, right? And it will not supply any of the hybrid component as such. So what we have here is the obturator nerve. Okay. Now, these were some of the questions that the students were able to recall. Very quickly, we will also try to get hold of the more authentic questions and possibly rephrase and redo the session. But this is a quick revision of the questions that were asked in your NEET PG 2024. All the best for your results. Keep your fingers crossed and hope for the best. Thank you for joining this session.